EV-103 is a clinical trial in patients with metastatic urothelial cancer who've never had treatment for metastatic disease. And it's a combination of the data that we're reporting here is from the dose escalation and the first cohort on this study. So about 45 patients looking at the combination of enfortumab vedotin, which is an antibody drug conjugate directed against Nectin-4 on the surface of urothelial cancer cells. That drug in combination with pembrolizumab, which is a PD-1 antibody, essentially an immune therapy. Both of these drugs are actually already FDA approved as monotherapy by themselves in urothelial cancer. And there's some preclinical evidence that when cancer cells are treated with enfortumab vedotin, that it actually induces an immune response. The idea is to look at the combination of EV enfortumab vedotin with pembrolizumab. The idea being that by itself, enfortumab may induce an immunogenic cell death, or essentially draw immune cells into the tumor microenvironment. And the thought is to add pembrolizumab to sort of increase that immune response. So the study accrued 45 patients, and we essentially dosed with EV and pembrolizumab on a 3-week cycle. They got EV on day 1 and day 8, and pembrolizumab just on day 1. The baseline demographics were mostly men in the study. Most of them had good performance status, either ECOG 0 or 1. The majority of patients had visceral metastatic disease. So this was, truly metastatic bladder cancer. About a third of patients had liver metastases, which are considered poor prognosis. And about a third of patients had a high PD-L1 score. The majority of patients, or I guess the plurality of patients, had low PD-L1 scores, but it was a mix. And what we found, what was really exciting, is that when patients are treated with this combination, 73% of them, actually 73.3, had at least a partial response to therapy. They had some clear response to therapy. And that's compared to other regimens that are approved for this patient population, that's very high. I should mention, I may not have been clear when I first introduced the study, this study is being done in patients who have metastatic urothelial cancer but are not fit or not eligible to get cisplatin-based chemotherapy. Cisplatin is considered the standard of care chemotherapy, but it can be very hard on the kidneys and on the nervous system, and about half of patients are not eligible to get cisplatin. So in this patient population, which is already a little bit sort of a worse prognosis because they're not able to get cisplatin, we saw this very impressive response rate. Not only was it a 73% response rate, over 15% of patients had complete responses, meaning the disease was just not visible on CT scans after treatment. What was pretty, I think, exciting about this as well was that most of the responses, I think almost 90% of the responses, were observed at the very first CT scan. So within the first 6 to 9 weeks, almost all the patients who were going to responded. The other interesting points for the study were that not only was there a high response rate, but the responses appeared durable. So the median duration of response for a patient who starts responding is over 2 years. It was 25.6 months, which is in urothelial cancer is quite long. Most other drugs, the median duration of response is usually measured just in months. It's usually less than a year. So the fact that we were seeing this really long duration of response is, obviously is a very good sign for patients, because some of these patients, even at the time of the data cutoff, are still responding to therapy. It's a single arm study, so we can't really compare it directly to another study, at least not in a statistically valid way. But the median PFS was over a year, and the median overall survival was 26 months, which again is really, I would say, very impressive for this poor prognosis patient population. The side effects of the therapy were, this is an update of the data had already been presented previously. And so the side effects of the therapy, we didn't really see any new signals or new side effects that we hadn't known about before. And they're actually very consistent with the individual side effect profiles of enfortumab vedotin and pembrolizumab. So at least from the initial data we present here at ASCO, doesn't seem like there's any kind of synergistic toxicity or combination toxicity of the two drugs. The most common adverse event was peripheral neuropathy that was seen in over half of patients. Fatigue was quite common, and then rash and other types of dermatologic toxicities were seen as well. The skin reactions happened in about 2/3 of patients. They were only severe in 20% of patients, meaning grade 3 or above. The median time to onset for the skin toxicity was generally within the first cycle. So patients knew very quickly if they were going to have any kind of adverse event like a rash or other skin toxicity. The neuropathy took a little longer to develop. It was about 2 to 3 cycles in that we saw the initial neuropathy. Most patients who had dermatologic toxicity, the dermatologic toxicity got better. In fact, 90% of the patients were able to have some resolution or improvement in the dermatologic toxicity. And about 2/3 of the patients who had neurologic toxicity, mostly peripheral neuropathy, had improvement in the peripheral neuropathy with either treatment break or dose reduction. Or discontinuation of the drug. So while it does occur, it seems like it is at least treatable for some patients. The other side effect that was, or I should say, adverse event that was of special interest was hyperglycemia. This has been reported in multiple studies of enfortumab vedotin before. We actually only saw it in a minority of patients. Only 11% of the patients had any hyperglycemia. And these were, again, manageable in all the patients with either treatment discontinuation or medical therapy. We didn't see immune-mediated side effects at any higher rate than we would expect with just giving pembrolizumab alone. And so that was somewhat reassuring. So this regimen, this combination of enfortumab vedotin and pembrolizumab, I think demonstrates very promising activity. We're seeing response rates and durability, duration of response that we've really never seen before in a cisplatin-ineligible frontline urothelial population. So this is the data presented here is one cohort, or really two cohorts, of a much bigger study. So currently there's an ongoing randomized cohort which compares enfortumab vedotin alone to enfortumab vedotin plus pembrolizumab. And this is going to really give us a better sense of what the true activity of each drug is, by itself, as well as the combination. There's a phase 3 trial actually in the same patient population, which is looking at enfortumab vedotin and pembrolizumab in the frontline setting. That's EV302. And that's going to be a much bigger confirmatory study for the findings here. So we expect those findings in the coming, likely in the coming years, and that'll really give us the sort of highest level evidence of the activity of this regimen.